Hey everyone, Joseph Shapiro here with my co-founder Sarah. Good to see you all. I can't actually see you, but good to see you. We're here for the first time in a while, just Sarah and I. We decided that for our own benefit and for everyone else's, hopefully, we would do a deep dive into New Jersey's psilocybin bill. It's here in my backyard. Sarah's in Colorado. We will likely do a deep dive into Colorado's psychedelics bill, but for right now, we're going to jump into New Jersey's bill, and we've put together some slides really for conversation purposes to help us facilitate our conversation about it. We're not going to be, tied to it, but we'll certainly circulate a copy once we're done. And I'm going to flash here. If you want to scan this barcode, you can be brought to the webpage to the Senate, the statement by the Senate on the bill, which is like a condensed version. I'll probably also we'll put a link for the full version of the substitute bill so you can read the whole thing. But really, you don't want to read the whole thing right now. For this, I think you could probably skim this 16-page statement rather than a 42-page whole bill. So, yeah, we can jump into it. Sarah, what do you think?
Yeah, that sounds good. And I think too, for somebody who wants to sort of get an overview of the bill and kind of dive into certain pieces, these slides will be really helpful, and we'll post them, of course, like you said, afterwards. But this will give you a good feel, and just know that the bill is still moving through the process. So there very well may be some changes, but this is where we are sitting now going into this next session.
Right. We, cautiously optimistic that this will be something that we can keep talking about and working on progressively. Otherwise, this is going to be the most information that anybody has right now on it until further notice. But we understand that as we get closer to the fall, unfortunately, we're getting close to the fall. And when that happens, we're apparently going to hear more about what's happening down in Trenton. So I'll move on to the slides and we can kind of start walking through them here.
Perfect.
So this is not, unfortunately, it's not an easy acronym, unlike CREMA, which was the cannabis bill in New Jersey. I don't think we can make an acronym out of this bill, really.
Let's just call it the mushroom bill.
Yeah, the mushroom bill, the psilocybin bill, PBHAS. No way, I can't make an acronym. But the Psilocybin Behavioral Health Access and Services Act. So we had to outsource our knowledge base about where the bill stands, really, even though Sarah and I went to testify and listen to testimony down in Trenton. It's still a little confusing, but here's an overview you can read about where these companion bills are. And the idea of a companion bill is that it's the same language moving through the two parts of the legislature. So the same bill is moving through the Senate as the Assembly. I guess procedurally, I don't know if the Senate has already, I guess it already did amend the bill. So then I think the amendments in the Senate then were introduced to the Assembly, which approved the amendments, but didn't send it on to the Appropriations Committee, which is where the Senate part is. So I think they're not exactly in lockstep, I guess, procedurally, but that aside, that doesn't really matter for the purposes of this discussion. But it is important to know the concept of a companion bill, that it's the same bill, it's being moved through through Trenton, attempt to be simultaneous movement. So what is it? If you follow again this code, there's a concise statement which is set forth here. This bill establishes a framework for the regulated production and use of psilocybin in connection with behavioral health care and preventative behavioral treatment. What does that really mean? So in the next slides, we'll see what it is and what it isn't. But for now, an overview is the New Jersey Department of Health will oversee a comprehensive licensing system. It's not so dissimilar to what we've seen happen in a lot of respects with cannabis, but also different in a lot of ways that you'll see. And what you're really talking about is a specific system that kind of circles around administration of psilocybin at a licensed center, rather than taking psilocybin home. It all kind of centers around a service center where administration happens, and all the steps leading up to that happening, and all the steps following. That's really kind of like the ground zero of what's happening. And so, in order to figure out how this all should happen, there's going to be an advisory board that'll be appointed within the Department of Health. 9 members are going to be members of the public. And they're going to do a lot of things, including addressing social equity. Right? Social equity is not nearly as big of an issue in psychedelics generally as it is in cannabis. I can make that blanket statement. Feel free to. I feel like I've talked to enough people who agree on many levels, but nonetheless, there is a consideration for social equity, which is in a lot of ways taken directly from New Jersey cannabis bill, as we'll see. So I really like these two sections, what it is and what it isn't. I think that helps a lot. I think that's like, and this conversation is good for Sara and I because we are speaking with local leaders and other people about the bill and just about psychedelics generally. So you learn you got to like cut to the chase really quickly. So what is this? You know, maybe the inverse would be easier too. Like what is it not? But first, what is it? It's a state regulated psilocybin program within the New Jersey Department of Health. It authorizes the growing and processing and testing, and it actually should say the administration of psilocybin products. But what should be pointed out here is cultivation and manufacturing are actually all collapsed under one license. Unlike cannabis, where you'd have 2 separate licenses for cultivating cannabis and manufacturing, it's all one license. And as we'll also see, there's no prohibition against vertical licensure here. So you could be a grower, a manufacturer, and a service center. Not all on the same premises, but there's no prohibition on this holding multiple licenses. Sorry, Sara, what were you going to say?
No, I was going to say, so there is a prohibition of that on that within cannabis. You can't own multiple businesses by one entity.
Well, now it opened up, but when CREMA first went into effect, there was a prohibition against. You really couldn't do vertical unless you were a medical marijuana company. And there's a lot of benefit to being vertical, as like many people may be aware, just generally. And so, yeah, we don't see any prohibition on that here, which is helpful. I guess just generally for somebody thinking about starting a business. And what's really important, and I think we're really important for a lot of people concerned about safety, is there's a lot of gatekeeping to getting access to psilocybin. It requires an ongoing relationship between a patient and a healthcare provider, and the patient has to have a qualifying medical condition, which is a to be determined set of conditions. And as you point out, Sara, it's not just the condition itself; it's actually a condition; it's a symptom of conditions, right? What's the distinction there? You know?
Yeah, totally. I mean, I think what's beautiful about that is like you can have symptoms of, but for whatever reason, by the person who would be doing the diagnosing, but maybe not quite meet full diagnostic criteria, right? And so you can have symptoms of, and I think that this, which we'll go into a little bit more in another slide, but I think that what's beautiful about that is it's a protection that's kind of built in for the public so that you can access these without having on your record a clear diagnosis that might get in the way of, whether it's child custody disputes or employment or gun ownership or life insurance or whatever it might be. It doesn't come down as a clear diagnosis on you. So I think it is really protective of the community.
I love that. Yeah. Because you never, these unintended consequences, right? Like I know people who in Jersey were getting medical marijuana cards and effectively they are, on record as being an illegal drug user, right? Because you are registering with the state of New Jersey as a patient who is being administered, able to buy federally illegal drugs, and that to me was always kind of like, I don't know if you'd really want to do that, because if you want to be a gun owner, you have to fill out a form that says that you don't use illegal drugs, and I think you'd be lying if you had a patient card and then filled out that firearms. This is me just anecdotally.
Yeah, no, totally. And I think too, when it comes to like life insurance policies, like what you're I recall like we're in one of the roles that I've worked in the past, in concierge medicine, like being very, very careful, like what you put on there as a diagnosis, because these are people who where a diagnosis could completely disqualify them from a, life insurance policy that they're interested in. So like really being very careful with how we kind of throw around diagnoses.
That's such a good, yeah, and this is a great example of how we can just totally go down the rabbit hole with just one definition, but it's so interesting. That's why this is helpful, even to me. So you have a qualified medical condition, and it's a healthcare practitioner, which is also like a whole subset of definitions. It's not just a doctor. And a preparation session has to happen after the referral to the service center. And this preparation session is done by a facilitator who is not a medical professional, right?
Can be, but not required to be.
And then you have the administration by the facilitator at the service center. And you pointed out, I had gotten this wrong earlier, that there is a required post-session integration session, at least one, right? Mm-hmm. Interesting.
Yep.
I feel like if I could be wrong, but in Oregon, it was optional integration session, and I could be corrected on that, but that's maybe where I had that in my brain somewhere.
I actually think you might be. I think you may be right on that about Oregon.
Yeah. So it's interesting that it's required but I think we all agree that integration is maybe the most important part of it.
Yeah.
But then integration, it can be done by a whole other subset of people, right? There's a different definition for the people who can do integration. Then,
well, what's interesting is they actually, and on the integration page, I have this listed out. It actually says that it needs to be a behavioral health specialist, which is interesting because it's, I think that kind of rolls into the idea that, but the idea of integrating a psychedelic, a non-ordinary state of consciousness and experience within that state and that's what integration is, right? Integrating it into your day-to-day life, your 3D life. And I think it's important that whoever is running the integration therapy session has an understanding of, work helping people integrate these non-ordinary experiences into their day-to-day life, like having a connection there, but they're not really specific. And it's interesting because facilitators in a lot of the current facilitator training programs actually train on integration. So it'll be interesting to see how those end up playing out.
Yeah, I would have liked to have done it now that I'm looking at it like a column comparing the definitions, the people who can be healthcare practitioners versus behavioral health care providers. And I think there is some overlap, like a Venn diagram, but like I'm seeing like a psychiatrist can be a behavioral health care provider, but only a psychologist is a healthcare practitioner. So we'll have to look at that.
Yeah. It's interesting because psychiatrists are more of a healthcare practitioner in the sense that they can prescribe medication. Psychologists can't prescribe medication. So it's going to be interesting to see how I'm assuming that's going to be the advisory board that's going to help sort of determine what are the qualifications of the person doing that integration therapy. And something else. Oh, go ahead.
No, well, but if it's in the law, these are the parts that are in the law, right? So I don't know to the extent that this is going to be ultimately how it plays out. Whatever the definition is, it is. I don't know if they'll be able to expand on it. You know what I mean?
Yeah, it'll be interesting to see if a facilitator who has been trained in integration can also then come under the umbrella term of this mental health provider.
Mm-hmm. No, it's interesting. So let's talk about what it isn't. I think maybe even more. I think maybe if I did this again, I would do it in reverse. I think what isn't? It's not legal on the federal level, because sometimes I talk to people about New Jersey's psilocybin bill, and they'll say, well, how is the FDA's denial of the approval of MDMA as a drug, how's that affecting New Jersey's bill? And I'm like, not at all, because it's not as it says down here, it's not related to FDA clinical trials at all. It's not a dispensary model. It's not a personal use model like in Colorado, where there's the ability to home grow and gift. It's not decriminalization either. It's not reducing penalties. There was a prior law that was passed that reduced penalties for psilocybin, but that's not this. And it's also not federal or state right to try laws. I didn't even know how to qualify that, to distinguish it, except for the fact that right to try laws are where someone's been trying to get some treatment for an intractable disease, especially if you're like end of life and you need something experimental. And if there is something that's promising, a drug that's being developed that's promising but not widely available yet, you should be able to get access to it. Psilocybin is a breakthrough therapy. It's been determined to be a breakthrough therapy under some clinical trials, and so therefore it should be a drug that people should get access to through right to try laws, but it's not. Actually, that's actually really relevant this week because there was oral argument. It was this week, or it was in the last couple of days, oral argument in the Ninth Circuit about right to try and rescheduling of psilocybin. But yeah, that's not this. There's really no overlap here, right? This is the state regulated model to get access to psilocybin, and really none of those other things affect this. Like, again, could be corrected. If anybody has any comments, please let us know.
I'm curious too, like when it comes to right to try, let's say, for example, the list of qualified medical conditions is only this big and somebody has something out here. Would the right to try law then apply to the person who wants to utilize it for a non-qualifying condition?
Yeah, I mean, I think so. I'd almost be surprised if somebody who would be able to get access to psilocybin through right to try wouldn't also somehow have a qualifying condition. You know what I mean? So I almost feel like the psilocybin bill addresses the gap that we're seeing in the federal right to try laws, where the government's not letting doctors get access to Schedule I drugs, even though they're already considered qualifying as breakthrough therapies otherwise and should be accessible. So you get these state regulated models, but obviously state regulated models are only state by state. Everything's happening within this state in this bill. Gotcha. Even strangely, patients are defined as residents of the state, which I don't know if that was intentional or not. That would mean that only New Jersey residents can get access to this, which, as we know, in talking with Oregon service center operators, that would be detrimental to New Jersey operators because there are people coming from out of state to get access.
Yeah. And I think, there's so many, I can't think unintended effects from that can happen. And I'm wondering if that's something they're considering, because as we've heard it in conversation, it's not something that's really kind of come up, but it is listed as what defines a patient. So yeah, I mean, it can be, if New Jersey is like this beacon of, of freedom and allowing this sort of, therapy, then why would you not want to, maybe years before other states in the surrounding area kind of implement something like this. So why not invite that in? That's tourism, that is a lot of other things. And it's also helping like the greater good.
Yeah. I'd be interested to know, like, as we say, if it's a feature or a bug, right? that definition. So we talked about this already a bit. Who's a patient? Yeah, must be a resident of the state and 21 years or older. Or older. I can't stand spelling it. I'm sure that's fine. No diagnosis required, only symptoms, which is really, again, we talked about that. It's such a, it seems like a nothing distinction, but it's a huge distinction, right? Yeah. And I don't know how they're going to, this is interesting. How would a patient establish that they already have a relationship with the referring mental health provider?
Yeah, I think that's going to be interesting to see what they determine that is, because I think that also will become prohibitive to people outside of the state. So let's say they're doing therapy with a therapist, but this therapist is now out of state for them and maybe out of plan. So I just feel like that there's a lot of things that can get complicated with that established relationship.
Right, because we know, to paraphrase, that these mental health professionals can't have a relationship with a patient solely for the purpose of giving them a referral.
Right.
So then, you're a patient, you're like, I really think I have to get a New Jersey doctor to get access to psilocybin services. So I'm going to switch and maybe move my depression treatments or whatever it ends up being to a new doctor. And then the doctor's like, no, yeah, I think you should definitely go to use psilocybin therapy, I've seen great benefits for my other clients. But then it's like, well, maybe we should wait 60 days or 90 days so it doesn't appear like I'm just giving you a referral, right? So what's that going to look like, really? If you're a doctor taking on a new patient, how long do you have to wait? And I hate to put like just general questions out without knowing. I'm sure there's an answer somewhere, but that's that. I think that's the whole point. We're allowed to be asked questions that might be dumb on this call.
Exactly. And to take wrong, and if we have an incorrect assumption of something, I'm really looking forward to hearing like feedback on this of like, well, we have this thought idea, or this is how this is going to work. It'll be, yeah, but I think it's important to have like these discussions around it.
Yeah, because especially as we have, we were supposed to have a presentation to a local municipality about the bill and kind of doing what we're doing now. And I'd much rather make the mistakes here than in front of council members,
Amen.
Yeah. So, mental health professional. So here's that list. So psychiatrist and psychologist, okay. Obviously physicians, that seems obvious. What are your thoughts about like would know better, Sarah, like the NP versus the PA?
There are certainly nurse practitioners who specialize in mental health. That is what their nurse practitioner license and training and certification is in mental health. But and I want to add to this also that there is a component within the bill that states that there may be additional I don't know if it's I'm trying to remember how I had it on there, that there's that who can refer to a service center is actually not going to be just everyone. That there may be some additional steps that they have to take to be able to make those referrals.
I'm looking at this. I'm looking at the definitions, and it's actually not. I don't know. Is it mental health professional or is it healthcare practitioner? Is mental health professional even the right term?
I have to pull it up, or I have one or two ways I can pull it up.
No, I was looking up. I typed in menthol. Menthol is not the right term.
Quite the opposite.
Yeah, mental health. Yeah, no, there's not in the bill. So that term should really be
health professional,
healthcare practitioner.
Healthcare practitioner.
Right. So a healthcare practitioner is the physician, psychologist.
But I imagine too, though, there's going to be a piece where it's going to have to be within somebody's scope of practice,
So there's a behavioral healthcare provider. We'll have to, before we circulate this, we'll make sure we double check that it's like that it is
mental health
right definition. Provider. Yeah, because there is some overlap between mental care practitioner versus healthcare provider. But anyway, these are the people, whatever they end up being, are the ones who can make the referral after having an ongoing relationship with the patient, who then needs to have the qualifying medical condition.
Right.
And so, I think, I don't know what the referral actually looks like. I don't know if they just, if there's a form perhaps that'll be filled out and sent over to a service center, or if it's given to the patient who then can go to any service center. It would be interesting to know if the doctor, if the referring professional is doing the referring directly to the service center. That's a whole, what does that mean versus especially in light of the advertising restrictions that we're going to talk about later.
Totally. And I think it's important to sort of, even in that advertising conversation, like that, just like we have the choice of which hospital we go to, people should have the choice of which service center they go to. So it'll be interesting to see how that information is. And also too, you may want to, as the patient, you may want to go to the service center and walk around and get a feel for the people, decide whether or not that's where you want to have this really huge experience. It'll be interesting to see what that workflow ends up looking like.
Yeah, with the lack of ability to advertise, I don't know if advertising can't mean that you can't have a website. And we know at Oregon, they can't advertise, but they still have websites. So arguably you could see, does that mean you can't?
What kind of SEO can you do if you're like not allowed to advertise?
Yeah, what's the extent of the advertising? I mean, you can't have social media. I think that's going to be a major issue. I mean, the ability for the industry to support itself is going to be huge. because the last thing you need, I mean, one of the things you heard from Oregon is, you know, they're running out of money. I know that means more like appropriations and money for the program, but I think that also you're not going to want service centers closing, as we've heard some have already done elsewhere. I'm not aware of any. I'm sure it's already happened in New Jersey of any like dispensaries already closing for lack of business. Um, but who knows? Again, a completely different model, the consumable cannabis versus this more intensive in on premises administration, completely different. Um, so, so you're a patient, you're referred by this professional to a service center. You decide to schedule a session and you hire them or you pay them, you retain them. And so they have to, whatever it's called, you hire a service center. I don't know. Um, and then these are the parts of the preparation session, right? They have
Yeah.
to on their so this is where the legal work comes in too, right? There'll have to be informed consent waivers and safety screenings. In Oregon, we saw they have some of this already done for you. They've already made these standard forms, which would be super helpful. People don't need to be recreating waivers over and over again. I think that would be a huge thing that the advisory board should do, is do all the standardized forms, because it also should protect everybody from liability. If you have standard forms made by the DOH, it also should save a lot of money on legal work, to not have to recreate the wheel.
Yeah.
Um,
Totally. And I think it's interesting here too that the service center has to verify the referral. So I don't think it's going to, or, it may end up being a direct referral. What would be interesting is if all of those providers who are qualified and have met whatever additional requirements the Department of Health puts in place for them to be able to refer, if they have an entire list of every single licensed service center and all of the licensed facilitators so that the person can then go on and start exploring on their own. But it's interesting because the service center has to verify the age of the patient as well as the referral, which maybe that just means like calling their referring provider. Hello, did you refer this patient? Okay, perfect. But what's interesting is that the service center, it says that they cannot retain proof of the
hmm.
referral or age, which I think is it's just interesting. It's like, well, I'm sure there must be something that they're thinking to provide protection for the service center in case for when they get audited.
Yeah. Um, yeah, you would think that they'd retain some kind of proof that you went through this procedure. Um, a lot of this, a lot of the kind of like minutia, becomes like less and less interesting. It's like, all right, that'll all sort itself out. It's like you really wonder, and we've talked about this, like how does this all really operate? When it actually comes time, like, and especially in light of the illegality on the federal level, how are you going to be forming different entities to run the service center, versus, you know, like how do you structure this for tax reasons, for liability reasons? But anyway, yeah. So the preparation session is required, and I wonder what, other than like kind of covering the service center's bases, uh, and then following the regulations about ruling out contraindications. It's like I really wonder what a service center is doing and who is doing it. Is it a facilitator at the service center, or is it the service center themselves?
Yeah. Yeah, I mean, I imagine though that all of these, so it's the people who I know the facilitators trained in sort of going through this and also kind of going over goals, which many people may know as like, what is your intention for that journey? And so really helping somebody to become really, I mean, let's say they're referred by a healthcare provider who maybe isn't all that familiar with the actual process and the experience. I think that this is where the facilitator, somebody trained in facilitation, can come in and let's talk about intention setting, for this journey. And it seems like it's a little bit of its own like therapeutic session, is what I gather from those in Oregon, and also sort of again like going into goals of care. Goals of care sounds very like sterile and my plan of care as a nurse. But goals of care is really intention setting. So helping somebody to get really clear on their intention, and then even offering, whether that means, breath work and all these other meditation practices to help prepare for that actual session or the actual journey with the administration.
Yeah, and I'm looking at the bill. And it does say that the psilocybin service facilitator is responsible for doing a lot of these things in the preparation session, ensuring the patient completes the preparation session prior to administration, ensuring the patient is furnished with verbal notice and written copy of warnings and disclosures, determining whether the patient is precluded from receiving services. So it's interesting that it's a service facilitator who is, again, an independent party who may or may not own the service center, right? So then you're the service center where this is happening, but you're having the facilitator who probably operates under their own autonomy or under an LLC or some other entity.
Yeah, which is what we kind of saw with Oregon, is that's often the case where the facilitator is their own entity, and then they are sort of consulted in. And what's interesting too is, whoever is doing the preparation session, this is like the relationship building. Just like, they're requiring a relationship with the healthcare provider who's making the referral. This is the beginning of a relationship of somebody who's going to be sitting with you and supporting you, like through your actual administration.
Yeah, and they're doing a lot of administrative work up front, signing waiver. They're making sure the patient signs waivers.
Yeah.
The psilocybin services safety screening tool. And
Which I wonder, I feel like, so it's actually, those things are actually listed in both parts of according to the bill, listed in both parts of the preparation session, as well as the administration session. And I imagine, especially like with consent forms, it's important, I think, like there's a whole discussion within the medical community of like when consent forms should be signed, and not signed so far away, because somebody can then, let's say they change their mind last minute, they can all, like they can kind of like retract. And they also, right before going in, reviewing those consent forms of like, okay, yes, I am ready and I am doing this and I consent to all of these things.
Yeah, I'm sure again that there's a lot of the filling in the lines here that can be done by the advisory board. It's just like, I think the goal of this conversation is helping me, really just conceptualize where are the obligations, like whose duties and obligations are what. And the facilitator definitely has a lot of obligations here. But again, going to the concern from some of the senators or assemblymen about the training for facilitators, nothing they're doing is that in depth or complicated where it would require more than a high school degree and specialized training, it seems, right? They're not a doctor or a psychiatrist or a psychologist.
They're not prescribing. Totally. At the same time, though, the facilitator training is not, I don't think is like a light training. It's very intensive. Oftentimes they are 6 months to a year long. And, I do think that how you help somebody, as the facilitator, and I'm not somebody who's trained in this, but to utilizing a non-directive way, how do you help somebody stay safe and navigate those spaces without, causing harm within that space, without directing their journey, with allowing them to stay within their space. I think there's actually a lot of skill to that doesn't cross over to any other medical profession, space and like
really
training.
Non-medical, right? I mean, it's really not quote unquote medical what they're doing at all, right? And so here's the administration session, which happens after the preparation session. Perhaps they could be contemporaneous, right? You could do a preparation session right before.
I would be surprised if they don't require some time to really prepare. I imagine the advisory board that is going to have a lot more experience in this space will probably recommend some time to really sit with those intentions and kind of make sure that those, help build up those skills to be able to go through the process. I do think what's interesting here is that it must take place at a service center, and it will be interesting to see how this sort of broadens out, especially when we start talking about end of life care for people who cannot physically make it to a service center.
Yeah, I believe Oregon's working to change those rules. It seems like we talk about equity. That's one of the things, making it accessible and making it fair. It's not exactly, that's at the top of the list there, I think, is if you can't make it out of the house but you want one of these sessions. I feel like they'll probably accommodate that, but to be determined.
Totally.
So the session is really the most expensive, seemingly, like the most labor intensive part of all this, other than the actual growing of the mushrooms and testing them. Like a lot of the work, it seems, the hours of work is put into the actual session, and actually setting up a space where this can happen. Uh,
Yeah.
as we know, the service center operations are probably going to be the hardest to do from many angles, including getting, because we had mushroom farmers on last week, and they described how you can grow mushrooms in the basement of an office building, like a 12 by 12, and have enough to run a business. But you can't really do that with a service center, right? You're going to need a place that's conducive to having the administration session. So,
Yeah. And
yeah.
also in terms of like labor intensity, I mean, the facilitator has, I mean, some journeys are 6 to 8 hours, and somebody, maybe they're a slow metabolizer, maybe they're, it was really difficult and they're not quite stable enough to go home. So having space, like that's where, and that facilitator is with them at all times, right? They are there, and kind of like their role is providing affirming, non-judgmental, culturally competent, and non-directive care. But they have to remain with that person at all times. And so I see that as like definitely labor intensive. And also, what is going to determine when somebody is safe to go home? And I'm sure all of these are going to then come out of the Department of Health's advisory board. The other thing I kind of want to point out is the sober facilitator. And as I mentioned to you, Joe, earlier, in a state regulated model where, this is a very medicalized, avenue of going down this, of course, having a sober facilitator is really important, even just from any sort of like litigation sort of aspect of it. But that's not to say that when that other areas where facilitators are not sober doesn't mean that that is necessarily wrong. If you go down into the jungle, of course, and you're working with ayahuasca or with wachuma or a lot of these other plants within an indigenous space, the person who is serving is partaking with the person. So although the state is making it required that the facilitator is sober, that doesn't necessarily mean that it is wrong in these other situations.
Yeah, I think that there would be some way to get the benefit of both worlds, where you have a facilitator facilitating per the regulations, but you'd have somebody who's also in a group session guiding. I don't think there'd be any reason you couldn't have interaction between patients at a group setting, and I don't see any reason why you couldn't have a de facto, main guide who's interacting with everyone else if everyone consents. So I feel like you could probably still get that. I think get the benefit of that.
Yeah, like with with like the curandero, right?
Right.
Curandera, right? Whoever it is that might be, and allowing like live music, which of course none of that is delineated in the bill and will come from the Department of Health. But yeah, whoever is guiding the music for a group journey, for them to be within the same realm or space as the participants, so that they can sort of allow the music to flow through. It'll be interesting to see what comes out of this, and if that's true, that's really possible, because I think that would be really beautiful.
Yeah, so each service center shall annually report to the Department of Health the total number of group administration sessions provided and the average number of patients participating in each group. I mean, so inherently in part of this bill is the allowance for group sessions, which also, I mean, from a financial standpoint, is more affordable for one facilitator. Let's say that they allow, 6 to 1, then everybody's splitting the cost of a facilitator and or the space, versus one-on-one, which is just, less affordable.
Totally.
So, we have a continuation of administration session. Dosing and medical oversight. Yeah, dosing's interesting. Hopefully we'll get someone, we'll talk more on another call about dosing and dive into that, because in Oregon now, with the testing and the dosing, apparently that's been a really positive thing about a heavily regulated model. You get a real clear understanding of what's what,
Yeah,
the amount
totally.
of psilocybin, I guess.
And I think in Oregon they do limit it at 5 grams, or I think that equates to like 50 milligrams of psilocybin. But they do like cap it at 5. But I like that. I think at least in the bill that there's like no minimum or maximum, at least stated at this point, because I do start wondering whenever, are they going to allow people who are on SSRIs, and if they do, because those people will need a higher dose. And I've known people who've even 7 grams didn't really touch them on an SSRI and they needed a little bit more. So it'll be interesting to see like how that's navigated, because it's interesting in the bill, they talk about risk factors and contraindications, but there seems to be a lot of gray area of like that there is space to work with somebody who may have something that may otherwise qualify as a contraindication, but that dosing or how you work with it, there definitely seems to be some area within the bill where there is gray. Certainly there's going to be some things that are absolutely contraindicated, but I like that they're really allowing for space within that.
It definitely, I mean, generally speaking, there's not a whole lot. I recently wrote that short article about any zoning regulations that might affect the operation of a business, and it's fairly limited. A lot of this is left up for the regulations, which are to be determined by this board. So then you're going to have the board, and they're going to form committees and/or subcommittees, and everyone watching could arguably get involved, even if you're not a board member. They could even, I think there's a possibility they could even bring in, more parties to serve on boards as necessary. This medical oversight, I don't think we've seen this before in any other bill where a service center has to have a physician or an EMS service contracted to be there in case of emergency, and medical directors are separate. You have to have a medical director, right? And is it or medical director?
So they list them as two different. And I'm sure the medical director, if he is who would be a physician, could probably qualify as that physician who's available during hours of operation. But yeah, they do list them separately. But
you're right. It's like it's disjunctive, as they say. So it's like the service center shall either employ a physician as a medical director or contract with an emergency medical services provider approved by the department. So the department would then say, okay, here's a list of half a dozen, contract with them, get a contract with them. What are they charging? Who knows?
Yeah. And are they trained in like assisting within somebody who's in an altered state without causing any additional like harm?
Yeah, that's going to be a whole nother subcommittee, right? Of like EMS providers and what they should be considering and what they should be doing. And so lots of things to do.
That regulatory board is going to be so busy.
I think these EMS providers are going to probably be, if I had to bet, I'd say it'd be easier to hire one of these EMS providers than it would be to get a doctor to be the medical director when you're dealing with a controlled substance. And a lot of medical directors as a physician. So
yeah,
they can put their DEA license at risk, right?
Totally. And you know what? I actually think that in the bill, it says that like the medical director, I think it might be medical director, and it might say, this also for the physician. I may be wrong on that, but that they are separated from the psilocybin administration so that to protect from it seemed like a protective mechanism kind of placed in that.
That's interesting. I have to look that up. It says, the medical director shall not be involved in the provision of psilocybin services. I guess that means, they're not involved in the transfer of illegal drugs effectively. And
and I think what's important here is like out of Oregon, from what we've heard, I think somebody say there was like maybe 1 or 2 of all of the thousands of administration sessions that they've had, they only had like an EMS that needs to be called 1 or 2 times. It was very, very low out of thousands. And again, what are the emergencies that may happen? Of course, there's, the risk of like somebody going into a manic episode or a psychotic episode, which is very, 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 very low.
And to that point, hopefully you don't have to have an EMS service as a service center on retainer where it's like, pay us X amount of thousands of dollars a month. Hopefully it's just per incident, right?
Yeah, and that'll make service centers so expensive.
Right. Well, it would save it a lot of money if it's just per incident. Then you can say, as a service center, when you're building out your business model, you can say, well, we'll put in a line item for EMS services, but we could probably, if we say 1 or 2 a year and each one is $1,000 a pop, we can annualize that at like $200 a month expense. You're like, okay, that's doable.
Yeah, and that's 1 or 2 a year out of the entire state.
Right. So that'll be, that's another thing that'll be interesting to see how it's addressed. So they've gone through the administration session. Likely, no one has taken advantage of EMS services, right? It's just, and then the therapy integration session. So one has to happen. We don't know when it happens. I guess per normal practice, that would probably be the same day or the next day, right? Pretty
Well,
competitive.
what's interesting is the facilitator has to reach out to the patient within 72 hours for a follow-up. Um, so that's kind of a little, interesting because that could be an ideal, integration session time. And they have to be able to provide resources, but that's separate from the integration session. So at least they have like that follow up. So if they can't get into the integration therapy session, and the other question will be like, it'd be awesome if they can, these integration therapy sessions can be group sessions. Cause as we've heard from other, service center owners, group sessions are incredibly valuable when people can like have this like shared experience and talk about it. So it'll be interesting because that will also cut down on costs as well.
That's a great point. It doesn't say, it says between a patient and a behavioral healthcare provider. I guess it doesn't necessarily mean just one-on-one, but it could be read that way.
Yeah, I mean, they do group therapy. Group therapy sessions are a thing that are covered by insurance.
Hmm.
So it's not an uncommon thing, but it would be, yeah, this way maybe if somebody who is a mental health care provider who is also trained as a facilitator and can really kind of help work within those all, with those altered states and integrating them.
Um, yeah, and it says it can be remote, right? The preparation session, I think, and or integration can be held in person at the center or any other appropriate location. Interestingly, which is
Mhm.
that opens up a lot of options, or remotely.
Yeah, it opens up a lot for community, a lot for community.
Yeah, I think the creativity of like professionals and the people who are opening these businesses in collaboration with the professionals of like thinking like how do we do this to maximize benefit and value for people while still doing it within the confines of the law. I think you're going to see a lot of creativity. Um,
Yeah.
so so the manufacturing, obviously manufacturing, which I know our friends prefer to refer to it as cultivation or farming,
Yes.
right? And
Yeah.
and then testing labs. That all happens obviously before anybody before. So chronologically, this slide could have been much earlier, but we're not. Who's following the timeline here? So it's like,
And this one I'm so happy to see in this that they cannot restrict the use of naturally grown mushrooms or require a synthetic psilocybin as long as it meets quality and safety standards. And they can't require a patented product either,
right.
which I think I might have taken out of this one. But, there can be these alternatives, which are synthetics, but they cannot restrict the use of the actual mushroom and plant, which whoever added that, thank you so much.
Yeah. Yeah, that's such a good what do you call it, backstop
Mhm.
provision. But so a lot of things that we saw in cannabis too, with packaging restrictions, making sure you can clearly see what's inside. I don't think there's as much restriction on what products can be made from psilocybin mushrooms as there are in Oregon. I could be wrong. Um, It'll be interesting to see what can be manufactured and what can't. Um, and you got standard record keeping, sourcing. A lot of this, again, very normal for a controlled substance regulated product. The zoning is interesting, and this is what we discussed in that article. Uh, Luckily, it didn't also say 1,000 feet from a park or a house of worship, because in some, like where I'm sitting in Jersey City, I'm like 1,000 feet from anything, everything. There would be no place you could do this, and because the zoning doesn't just apply to manufacturing. This zoning is applicable to any business. Um, and it actually can be 500 feet from an elementary or secondary school, with the caveat that it could be 500 feet if the service center. Um, and actually, look back. I think actually, let's look at this because I believe the zoning. Let me fact check myself. Um, yes, this zoning actually, from my reading, only applies to service centers. So this zoning doesn't apply to manufacturers, to cultivators. So it's a service center shall not be approved for a location that's entirely zoned for residential use, or that is 1,000 feet from an elementary or secondary school. It can be approved up to 500 feet of an elementary and secondary school, as long as it doesn't use signage that's attractive to minors. So in my mind, that means that 500 feet is okay. Nobody's doing anything that's attractive to minors. So I think 500 feet, if for everybody's just like working knowledge, I think you could say, okay, as long as we're not 500 feet from a elementary or secondary school, and I think secondary must mean up to high school. I don't know what secondary school really means. I'm going to assume, but that's the only restriction is the amount of feet from a school and residential zoning. That doesn't mean that municipalities can't do more restrictive zoning, right? This is just the bare bottom, language. So that's as we know, that it seems innocuous, but the zoning issue is like maybe the biggest restriction on this business and / industry in the whole bill, or the lack of any proactive other zoning measures. You know what I mean? Like if it could say, alternatively, the bill could have said that the zoning could be anywhere in a town with these small exceptions. Instead, it just says this is where it shall not be. It doesn't say where it otherwise can be. Although it does say that towns and municipalities should not take unreasonable steps to any regulations that are unreasonable or otherwise. I have to get the language, but the point is, I'm pitching Psychedelic League. The reason why we're needed is because there's a lot of play in there, and we want to make sure that people understand that you don't necessarily need to stick a service center in like an industrial warehouse, zoned area. So
totally. And we'll have somebody coming on in another few weeks to talk about land use.
Yeah, I'm really excited for that because I learned a lot from our initial call with her, and it's just really good. It's a really good, sobering view of how intensive it can be to go through that process and how much real communication, like messaging, needs to happen at the local level to get that done. So facilitator training and licensing, we've spoken about this in our previous talk with Dr. McLean and SoundMind.
Yeah. So this one's interesting. This is for New Jersey is different than others in that it will be modular and will be offered in both online and in person. And of course with an in-person practical, which is a more hands-on. And what that allows for is for people to take various parts of the course from whoever it is that they would like to take it from, however that's being offered. And then the advisory board and the Department of Health will kind of determine what the required hours, what the modules are, and what they're going to be covering. What's interesting is the licensing tests will be offered twice a year. I wonder if they will eventually move that over into so for example, when I sat for my nursing license, nursing boards, you kind of sign up with one of those testing centers. I feel like that could also reduce the costs on the state if they just do it through a testing center versus having like these two very specific dates of testing. And then the cost.
Yeah.
What's that? Yeah, totally.
Yeah,
you meet the requirements, you get the stuff from the state saying you met the requirements, you take that paper, you go to the testing center, you sign up for a date, and then you just go in, get on the computer and take it. So it's very simple. And there's you can test lots of people and lots of things in the same place. What I think is interesting also, and this is actually in relation to some of the other fees, they often state that the cost of licensing cannot exceed the costs incurred by the state, but also within that cost, they can start including some of the costs of the equity programs. So, they are putting that limitation on there. So, it'll be interesting to see what those costs of licensing ends up looking like.
Yeah, the rolling definitely makes sense to me. The idea that you have it like the bar exam is like twice a year, it just seems like you're going to be shoving a lot of people into some place. Who knows how many people, but.
Well, let me ask you this. On the bar exam, is there an oral aspect of it?
No. Yeah, I don't know why I laughed at that. There's no.
Well, so in medical boards, there is an oral aspect. So there is the
Mm.
practical, like the written, and then there's the oral boards, right? So like when you take, like that makes sense for it to be a set times of a year because you have to actually go in front of a panel and navigate a complex patient scenario. But yeah, if there's not an oral component of it, then having it just kind of
On
feels
paper.
cheaper, feels cheaper.
Yeah. I mean, no slight to my transactional attorney friends, but you know, I feel like that might be a big hurdle for some of them, um, to have an oral part of it. Uh,
The
I think
ones who don't
it'd
love
be a good
court.
idea. They should. The only oral part of it really is when you do your character and fitness interview, and you have to talk to somebody about, you know, any like, yeah, I got a ticket when I was 19 for, you know, something, and I'm an upstanding citizen now, and I have good ethics, and you should let me be a member of the bar. That's as much of the oral part as it gets, if I remember correctly. Um,
Like I swear I'm a good citizen.
yeah, yeah, you don't want to get caught up in that part. I was speaking with someone recently who they were older and taking the bar, and I said, well, I guess by virtue of being older, there was just more time for you to have more issues to have to talk about. Like the benefit of going to law school right out of college, hopefully, there's a tighter time frame in which you can mess up and have to explain yourself.
Yeah, that's
Yeah,
that's definitely a benefit to getting it done early.
yeah, just get it done. Um, so worker permits, another similarity to cannabis in New Jersey, where you have workers, they're not licensed business owners, but they are working for one, really. You know, um, interesting with transportation, how that's going to play out. I didn't see anything. I didn't see much in the bill about transportation.
Yeah,
But,
I thought I thought I saw it in under like distribution.
mhm.
Not I'm using the word transportation, but I thought I saw it under like distribution.
I'm sure
Um,
it's going to be an inherently a power of the manufacturers, the farmers, to transport, and probably the service centers. Somebody's
yeah,
going to have to drive it somewhere, right?
totally, totally. And I looked up the worker permit under the for cannabis workers, and it's like $25 per person. So it's not horribly, it's not exorbitant by any
Yeah,
means, but it is annual testing. So that's, another place within the bill to help sort of start balancing off some of the costs.
yeah. I'm sure it's going to be fairly low barrier to entry.
Yeah.
Um, but again, I don't operate a dispensary day to day. I could ask people who do and see how intensive. I really would be interested. Actually, we should actually, now that I'm thinking about it, we should bring someone on who in New Jersey currently runs a dispensary to get an understanding of, like, if by analogy, what would you prospective business owners, service center owners expect when it comes to like problems. Like I was surprised someone who runs a dispensary said the biggest challenge that they didn't expect was their tech stack, all the tech, all the servers, all the computers. Granted, they have like a sales business, so they have to deal with all of that. But metric is part of it, which is the tracking system, and that's built into that point of sale system. And I think you're going to have the same thing here. And so I think the tech stack is going to be a
Big
lift. You have to get
component.
a server and like security, and make sure all that.
Well, I imagine too, though, I mean, they're going to have like, this is all protected health information. So everything will have to meet all HIPAA standards.
Right. Yeah. Because unlike a dispensary where they just scan your ID for age verification, here there's more than that. Like you're getting some referral that has some kind of symptoms of a qualifying condition. And yeah. So
Protecting patient safety, like protecting patient information safety is going to be a huge piece.
that's something we hadn't talked about with prior service center operators that we had on the calls, but we know we have another one lined up, so we should keep that in mind
Yeah.
for our next question.
Next week.
Yeah, next week. Wow. Um, so advertising, this is super interesting, right? Because this was a major bottleneck. I don't know if that's the right word. It was a major challenge for service center operators in Oregon to get new
Mhm.
patients. Because let's say you open a service center, you have a website, you don't have the best SEO or anything. You're not the first or second or third result with Oregon psilocybin. You're buried on the third page. What do you do? You know?
Yeah. Yeah, hopefully this will be a situation where those who are referring will have a list of everyone who is. Just like, for example, here in Colorado, I've been getting emails of, updated lists of all of the approved facilitator training programs, right? And so hopefully, like, these providers will be able to share those things, and then then they can go to your website, and then that's where you can tell, like, who you are and what, kind of environment you create.
Yeah, I guess start now would be
Yeah,
one piece of advice probably. And then I was thinking from you remember phone books? Remember phone books generally?
the
So you
actual
should
phone
probably
book.
just call yourself a AAA psilocybin service center. So like
Oh, yeah,
when they
yeah.
make that sheet for the doctors, they're like, why don't you just go with, I don't know, go with the first one.
That is a really good point around naming.
Yes, that's
I didn't
free.
think about
That's
that.
free to steal. Anybody who wants to take that advice, you can open AAA,
Exactly.
AAA healing. Yeah,
Everyone's gonna start with an A.
yeah. Or if you want to be like, you know, really like if you want to think ahead, it's two steps ahead, go with a Z, triple
Yeah,
Z. Yeah.
yeah.
Um,
So it seems like, yeah, with the advertising, everything is very insular, like advertising to healthcare providers. Manufacturers can advertise to service centers and facilitators. And even within advertising to the patient has to happen within the confines of the service center preparation session.
well,
So yeah, there's a lot of it's very insular.
even the psilocybin service facilitators can't advertise. I think they're going to have to advertise all their other services. Like you're going to be, I do sound baths and other things. And oh, you like this non-regulated service I offered. I just so happen to do this. You
Yeah,
know, um, it's
absolutely.
very interesting to not be able to advertise. I got to say.
Yeah, I mean, because at first time I read through the bill, I thought it was really just saying that you can't advertise in a way that is attractive to kids or anybody under 21 or whatever that language is. But yeah, they're actually pretty strict on no advertising. So hopefully that's something that expands. There's at least an avenue because again, it's not about to me even in this. It's again less about the business and it's more about the person to have the right to know what is available and to choose what's right for them. And the only way they can do that is if you can let them know you exist and what
Yeah,
you stand for and what you environment you create.
it's another gatekeeping mechanism because they want to make sure that it's the licensed healthcare practitioners who are making objective referrals, right? As opposed to somebody being advertised to on Facebook and then going to their doctor saying, "Give me a referral." That's you want it to be like a top-down approach kind of thing.
Yeah. But I mean, patient autonomy who comes in and says, "Hey, I've learned about this and I feel like this might be really right for me." Like they should, there's a lot of like we want, people always talk about like, "Oh gosh, they dislike it when patients do all this googling and come up with all these ideas." And I'm like, that's actually what we want.
Yeah,
Like that's
yeah, it's
how
true. I
people.
do. I actually told someone the other day that I knew just enough about um, some type of law to ask the wrong questions. So, I do. Sometimes if you know just enough to be dangerous. But I guess in the point of with psilocybin, I would think perhaps, yeah, some patients might know a lot more than doctors. They're super busy. They're kind of staying in their lane.
But also
So,
too, like the person knowing what's best for, like kind of inherently knowing like this is something I want to explore. Oh, I'm on these medications that are contraindicated. Okay, well, how can I navigate that because I want to explore this? Or like it's all kind of comes down to like autonomy of the person, of the patient, of the
yeah,
every one of us.
perhaps advertising isn't going to be so much of a hurdle in the beginning when it's such a new, fresh industry. There's going to be so much news cycle going on around it that it'll reach people. It'll be word of mouth, and people will figure it out. Um, but as it just like as it becomes more, what's the word? The market becomes more saturated. Then you're
Yeah,
going to
and
be
again,
seeing that.
right. And we've talked about the idea that I think that they are going to allow for a limited number of licenses, at least initially. So that'll be interesting from a service center licensing. And I'm
Yeah,
sure manufacturer licensing, right? Because there's just a lot of ways in which, I mean, you want to be able to, yeah, be able to support businesses. And as we were talking to, Aisha and Steve last week, how much mushroom is really needed, how much is the cost of entry with that. So there's a lot of pieces around those limitations for licenses where
yeah,
it can be beneficial.
Yeah, the how to figure out how to have the volume of mushrooms be appropriate is is an interesting question.
Hmm.
So this equitable opportunity program. Um, this looks a lot like micro business licenses from New Jersey Cannabis's the CREMA Act, um, and it's about you know giving opportunity to people who live in distressed areas. Ultimately the distressed area will be determined by the Department of Health. Um,
Yeah.
we'll see what this really means. It seemed to me, honestly, I can't figure out
Yeah.
where the benefit will be here. Perhaps with limited licenses, like if this is really competitive, um, then this might be actually something to not gloss over, right?
Yeah. What's interesting too is, especially, I mean, let's look at like the cost of some of these facilitator, um, you know, the facility cost to become a facilitator. I mean, upwards of like 12 grand or so, and so hopefully this is something that will maybe also, they talk about licensing of the facilitator. Maybe there's also opportunity to pay for like training of the facilitator as well, which could be really certainly helpful, especially if there's somebody who wants to sort of work with specific groups of people. I do think, and you and I had talked about this earlier, that they are required to have more than 10 full-time employees. That's wild, because I'm not sure that there's a single operating service center that has 10 full-time employees.
Yeah,
So if that's really and truly a requirement that they pin on, I don't know who's going to qualify for that.
it says an applicant for a psilocybin business shall be eligible for participation in the social opportunity program if among other things they have more than 10 full-time employees, more than half of the employees reside in a distressed area. Um, I'm not sure what maybe they'll be given preference, right? Like what's the ultimate takeaway? Um, we'll have to look at this more closely and digest it, and maybe for another time, like just play out. I don't think I digested this. I understand there's a section of the equity program where it helps people get access to psilocybin services. That's one
Right.
thing that's kind of self-explanatory, but the idea
Yeah.
of assisting applicants get business licenses based on this criteria um,
Yeah,
is
what's interesting again is like, if you're applying for a license, again, like if you're applying for a license, you don't already have 10 employees. Um, and can you, with the volume of business coming, can you support 10 full-time employees? Yeah, so there's a lot of pieces I think that still need to be clarified
yeah.
on
We'll
this.
look through this more. It's worth looking at again because it could be more important than it seems. Like my initial glance was this seems like the micro business license, which wasn't such a big windfall for anybody as far as I could tell in the cannabis context. It wasn't like taken advantage of that much. It's kind of like, you know, but nonetheless, yeah, we'll come back to this.
Yeah.
And so that equitable social opportunity program is different from the equitable access program, which deals with what we said about getting access to services, which makes everybody knows that there should be scholarships, there should be subsidized access,
Totally. Totally. Yeah, I think this is going to be really, really important. Um, really important.
And,
And
and
it'll be
then,
again, like, and with our conversation with Jessica Tracy, how is it that, if it is a business where employees are, maybe not making as much, can the business actually offer services like this? So there's going to be state funded, but then also things that businesses can do themselves.
yeah, this is interesting. It's like a built-in subsidy, which I'm assuming will be funded by the DOH directly, which would be paying the service centers and facilitators for their work.
Yeah, and it looks like the money for that is going to be built into the licensing costs
Hmm.
and the costs across like the board
Right.
too.
Yeah. We're like a self-funded program, unless it's pulling money from some other area of the budget. you know.
Yeah, I mean, it'd be interesting if there's like mental health, funding for mental health, and if some of that can get shifted over towards something like this, since it is so impactful.
Yeah, I mean, it could be a substantial amount of money considering the price of services now. It could be, certainly hundreds of thousands, if not more, of dollars. So this timeline is very legislative, almost doesn't make a huge difference right now, but it's good to talk about. We talked about, the effective date, the buffer period, the 4-month effective date period. And I guess the important part is that it's like, we're talking 2 years after the bill goes into effect, is they're going to start accepting applications. I mean, that puts us out in 2027, maybe, by the time this comes
Yeah.
in.
And what's interesting is it says within the 24 months. So it's really truly like 18 months. They cannot accept applications for anything prior to the 18-month period, but then they have to start accepting applications by 24 months. So it's not, it's somewhere between this window.
Yeah, it's interesting. As you had mentioned on our previous call, because mushrooms can be grown on a much quicker cycle, there won't be any hand wringing around the timing of like the first crop and processing. It's like, I don't recall from our conversation with Alicia and Steve about what the time frame really is, but it seems like it's more like weeks than months, to get, and especially considering that one farmer can, I guess, hypothetically, conceptually grow for the entire state. It seems like there wouldn't be much lag time in
Yep. And
getting
plus
product.
there's drying, right? How long can they be dried for? So, you utilize a dried product,
Right.
not a fresh product. I mean, people do take fresh mushrooms. I have
Mm.
not.
Yeah.
But, and I think I think a bit of the hang up actually on timing is could potentially sit with facilitator training, because that is, again, like an intense process. But some schools or programs are 6 months, some are 12 months. But it sounds like from some of our conversation with others, like I've heard that there may be a grandfathering in, which would be really great.
That's definitely, when you think of like lead time, you're right. I think facilitators would be the longest lead time, at least equivalent with service center operators.
Right.
Because I mean, a service center will need to get zoning approval, and that can take as long as it takes, to get through a town.
Which is going to be where I think Psychedelic League comes in, and working ahead of time for people who may be interested in having a business, like really courting those municipalities so that there isn't pushback, and they want to see this come through. So there's not resistance and kicking a can down the road. Whereas, they want it to come in, they want it to start, they want to see their community, be able to utilize it. So like, hopefully with the right community, with the right municipality, with the right support, that can hopefully not be a years plus long process to get that approval.
Yeah, you're going to want to start, let's say they do pass this bill in the fall. That would be amazing. I'm not sure if that's plausible, but let's say they do. You're going to want to start like your zoning approvals then, right? Because it could take 6 months or a year just to get zoning approval. Then you'd have to start building out a service center, which can take many more months. You're talking at minimum a year for the zoning approval and the build out. And if you're talking 18 months before they start accepting applications, you do have to, we didn't get into this in the slides, but you have to have control of the property in order to have a license, like service center license. That could mean the same thing it means in cannabis, which is like, you can have a lease, or you can have a deed, or you can have an option. You can have some kind of contract saying you have the option to lease or to buy.
Is that something where it can be conditional? Like this deed or this lease is conditional upon getting, so that somebody isn't then trapped in a 10-year lease on a
that's very standard, where you have like this option, this lease, and you have an option to lease. But it also, the problem with doing that though is, as the prospective lessor, as a lessee, the one leasing the property, as a prospective person leasing the property, I've seen it where the landlord gave this option, and then in the meantime, somebody came in and said, "You know what? I'll pay you double the rent or whatever it is, right? And then they just break it. They're like, sue me. I'm going to just take this other one, and then you lost your location. So then you got to go find another location, probably in another town, somewhere where the zoning is proper. It's the biggest problem in setting up a business like this. Um, and
Yeah.
not,
And
yeah,
if I remember correctly, also to add on to the zoning part of this conversation, it can't be within a 100% residential area either.
it can't be. Yeah, there's no buffer zone for the residential area like there is in Colorado, if I recall. There's a buffer zone around, like you can't be within X amount of feet of residential. Again, don't quote me on that, but I do. This is months ago. I was looking into the zoning, but that's good. So you could be right on the cusp of a residential area, arguably, unless the town themselves put in a buffer zone. You know,
Yeah.
um,
Again, like all the importance of having early conversations with municipalities.
yeah, it's definitely going to be a coordinated effort because let's say you do want to be in a rural area, but then there's not no outside allowed, like or it requires some other specific structure. So hopefully, like with cannabis, the state will be very open and in on one hand, it'll be very open in allowing businesses to operate however the towns see fit. But on the other hand, letting the towns have carte blanche sometimes has unintended negative consequences too. So I don't think there's any way around it other than another plug for psychedelically. there's no way around it other than education, because I think the towns are going to have carte blanche and leeway to do what they think is fit for their constituency and in their neighborhoods. So I
Totally.
think just the only way to solve that is not through governmental legislation or regulation; it's through education. So that's what
Right.
that's what we'll do.
I want to get to Neil added a few comments in the comment section. So I'm going to
Oh,
kind of
cool.
review a few of those because I think he brings up some really great
Well, I'm glad
points.
you were. I was totally somehow. Oh, good. Yeah, I'm glad you were paying attention to the chat.
Well, what's funny is I saw them all on LinkedIn more than I did on the
Oh,
chat.
cool.
Because I have this as full screen, so I realized I was missing them all. So yeah, Neil Ustin, who's one of our advisors for Psychedelic League. Thank you so much for adding some of these. So he said you might get to this later, but there might be restrictions on individuals or centers advertising, but a public campaign to alert the public about availability of treatment could help direct people to the licensed practitioners. So that'll be an interesting piece if that we see that kind of come into play as well, if there is some sort of public service announcement PSA.
Yeah.
Um, even looking on here, right, that within 6 months, the state has to begin posting medical, psychological, scientific studies and research and any other information pertaining to safety and efficacy. So that is at least like one start, but seeing a much bigger push from the state would be really helpful.
Yeah, the CRC in New Jersey had a roadshow originally about the bill, and they said they were going to have a roadshow. It was like a lot of virtual, and it wasn't. It was somewhat education. It's been a while now, but they did try to do something like that. But you think about it, these agencies only have so much ability to get out the message. So again, more reason
Yeah.
to, especially if you're interested in this happening in your county or your town, you'll want to like start somehow doing it yourself.
Yeah,
You know.
totally. And even like finding, there's what I'm finding out here in Colorado, there's a lot of like organizations, small groups, like grassroots organizations who are doing work as a community. And I don't know that I've seen that as much in New Jersey. I know there is, there's a psychedelic society in Jersey City, I believe, and there's a handful of others. And there's also a Facebook group. So if anybody who's listening who has interest in getting involved on that grassroots, there are some small groups out there. But, I think activation on that level will be really a huge player because it's people talking to their city councils and making their voices known.
I mean, this is all work in progress, but we're working to fine tune even like a presentation like this. It's fairly complicated, and to get the information to be consistent and accurate across the board will be great, because it's one thing to have something in your town talking about psilocybin, but if somehow it's not presented right, our big concern is, great, we could get a meeting with a mayor or a town council. What if we turn them off to it somehow? So we want to make sure that at very least we have the most accurate information, so that we can go in confidently and not pitching. We're not trying to convert anybody. We're just saying, here are the facts, and that's why data is going to be so increasingly important for us to say, here are the facts from reliable sources. There's really no other argument that psilocybin's effective and can help you in all these ways. Just looking at the facts alone, this is something that you should consider, right? Not even getting the human argument. We should definitely lead with the human element, but it should also be like human element on par with the facts. We've talked about finding people in communities who are the right person to spearhead that argument, like a veteran first responder. Those are the people who are really going to get a lot of, they'll hold people's attention.
For sure. And I mean, especially when it starts expanding outside of even New Jersey and other states, it's having people who are connected to that community, who are from that community, who want to start a business in that community is going to be the best avenue in. And then Psychedelic League can come in as support. So how can we support you as an individual or as a potential business or as a community organization that wants to help educate your municipality? Like, we're here to sort of support, and see what sort of resources we can pull in for that.
I'm finally seeing the chat from Neil. Neil, I'm sorry I didn't contemporaneously respond to all your great messages here. You asked about ad restrictions on ketamine centers. I don't think there's any advertising restriction on ketamine center because ketamine is legally done as an off-label use. So I think now, can a ketamine center also have psilocybin? I don't know. I really don't. I mean, ketamine is a controlled substance, which would require a medical director being on the name of the ketamine center so that they can be administering a controlled substance legally with a DEA license. And so it's not it's not a state regulated ketamine model. So there is DEA involvement. So I would think the answer is probably no. You probably can't have ketamine and psilocybin in the same place because they would put the medical director at risk with their license. But on the other hand, the bill itself talks about a medical director being on a psilocybin center.
Separated from that.
The answer is yes, you could. I think it just depends on the risk tolerance of the medical director.
Yeah, and what could be really as we heard from Dr. Hannah McLean, and something she had a great idea to do it, and I'm definitely going to be putting out an article on this, of talking about ketamine as a mechanism to help people come off of their SSRIs to be able to sit with mushrooms. So that would be really kind of a cool business offering, is to have both of those. So we have a mechanism to help you get off of the SSRI, and then we have the other service, to help you as well. That's more of a psychedelic versus dissociative experience.
It's also good to think about the services being offered in different premises on the same property. I think arguably you could probably have them broken up. Like you could, if you had a 2-level building, and as maybe the same people, two different entities. One has a ketamine clinic on the first floor with the medical director. Same group has the other. I'm sure there's multiple ways you can slice it, where you wouldn't have to have the medical director's DEA license at risk. But I don't know. I would love to play that out. I think as we get closer, we'll start playing out business models. We know some people attorneys out west who've done this a ton already, and they already have thought through all the creative business models and structures to make sure that you can reduce tax liability, like 280E of the tax code, which addresses selling illegal drugs and not being able to take standard deductions. And how do you make sure you protect the owners of a business, which are subject to 280E from getting personal liability on tax issues. Maybe you don't want to use a pass-through taxation vehicle like an LLC or an S corp, so maybe you want to do a C corp. There's lots of things to consider when you're dealing with federally illegal substance. So
we'll have to find the right person to have on. To come in really sort of deep dive on what that looks like in other states, or how that's been sort of playing out. That would be a really great person.
Some of our colleagues have already done this a ton because they actively have a ton of, clients out west who are, I'm sure we don't have to reinvent the wheel, luckily, because of their work. We could probably, if they're willing, share some of their insights with us. So
Yeah, and I want to kind of go to another one of Neil's comments that we were talking about this EMS service that is required, or physician or emergency service that's required to be contracted. He said every hospital in the state might likely need some training in how to handle adverse reactions to psilocybin, since no hospital can turn patients away. Like EMS can stabilize a patient and then they need to bring them to the hospital. But yeah, that's another, especially like moving a patient into the hospital, can there be a secure place? Because your eyes become very sensitive to light in those situations. So bright lights, movement, and a lot of stuff happening, like having them trained to not, again, like cause harm in that, getting that person to additional help will be really important. Another comment that Neil made is, you might get into this later, but, oh no, hold on. Make sure I'm not. Yeah, I think that might actually be. Yeah, without advertising, the state will have to maintain a database for access. Cannabis. And as written, this EOP seems to restrict the business models available within the EOP. And I don't actually know what EOP stands for, so maybe, Joe, you do.
This EOP. Neil, I'm sorry. We're behind on this acronym. But what's interesting, what we're taking away from a lot of this is that equal like attention should be given. And we're hearing this more and more over these previous weeks and months. We should really think about giving information to healthcare provider organizations, because while it's really important to get the businesses set up in the towns, that's crucial. Nothing's going to happen until that happens. But then you have to have, because of these advertising restrictions and these EMS concerns, you're going to need all these healthcare providers to, number one, be aware of all this and feel comfortable making the referrals so there's a thriving business, and to know how to deal with people if they are having issues and not exacerbate a problem unnecessarily, right? Oh, equal opportunity. Thank you, Neil. This equal opportunity program seems to restrict the business models available within the EOP. Yeah, we're going to have to do a deep dive into this equal opportunity framework, because again, it's certainly, on one hand, lack of like diving into it on my own, but two, it's just not readily apparent to me what it really means, how it helps anybody.
Yeah. It's interesting that it is required, I believe, I think it's required to be in a distressed area as well. So it almost like limits where a business can be. If somebody who wants to take advantage of that funding and support, where does their business go is also restricted.
Yeah, the only thing I'm seeing right now benefit for this equal opportunity program would be they say the fee will be cut in half or less. So,
yeah.
Neil, you're a rock star. Thank you for for keeping us going. The comments really help us, and thanks for thinking this out loud with us. But we're coming up on an hour and a half in, and so we'll probably just end it here. But if anybody has any questions, then please tell us where we strayed or misstated. I try to point out our spelling errors and other discrepancies earlier, but please continue to let us know. And we're looking forward to seeing you on the next one. Next week we have another service center operator lined up, so we have this has given us a lot of good questions to ask her.
Yeah, absolutely. And also, we're going to be posting this slide deck on the LinkedIn page as well as on the resources page of the website. So know that it's going to be available to everyone there.
And full disclosure, we will take the opportunity to correct our mistakes.
Yes. Do one more review of us and all that jazz.
Thank you all. Thanks, Sara. It was fun.
Yeah, thanks, Neil. Thanks, Joe.
Yeah.